related series of outcome measures. Those are the ADLs, or section G1, as we're all familiar with. So just one more minute and we will begin. All right, so we're going to talk about ADLs, activities of daily living. We have section G1, and for the most part, we're looking at the performance side of the scale. So we know that we have both the performance side and we have the support side. The performance side is with respect to what is it is the current functional status of a resident, and then the support side looks at what amount of care did you have to provide for that resident. And so here we're looking, when we're talking about quality, we're looking at the performance component of the quality of indicator. Now, one of the things that I've mentioned several times, these are not measures on residents, although the resident is the object that we're looking at. What they're measuring is your performance as a provider of care. So these are quality of care measures. These are the ADLs that we'll be looking at today: bed mobility, transfer, locomotion, dressing, eating, toileting, and hygiene. Please note that I just want to point out this part of the slide where I've taken the word better way to do ADLs, and you can see that the first four letters of the word better is the BET, and that is bed mobility, eating, toileting, and transfer. By far the most important indicators in the system, in that not only do they impact a risk for the resident, they impact the funding directly in the funding model under what is called the ADL index or the ADL score, which we know goes from 4 to 18, 4 being independent, 18 being totally dependent in the area of performing those 4 tasks: bed, eating, toileting, and transfer. We also know that these are called the late loss ADLs. That's another term that's used with respect to them. And today we're going to be looking at early loss ADLs, mid loss ADLs, and the late loss ADLs. So we have quite a long session today. And what I'd like to do is just skip the introduction. So I'm hoping that you're not new today coming into the presentation, so that this introduction that I normally give, I'm going to skip over it rather quickly, so that, and it's the same one I've done every single time. So what are the measures that we're looking at? We're looking at 5 different areas: late loss ADLs, and there are 2 measures, there are 2 measures related to the late loss ADLs. That is, we're going to try to look at improvement in function and decline in function or worsened on late loss ADLs. The second grouping is the mid-loss ADLs. And here we have 2 quality indicators. One looks at improvement in mid-loss ADLs, the other one looks at decline in the mid-loss ADLs. Then we're going to look at the early loss ADLs, and again we're going to look at improvement or remaining independent. Also going to look at percent of residents whose early loss ADLs, that's dressing and hygiene, who remain completely dependent. So notice for both of these, it's just not a matter of improving and declining, it's improving and remaining independent. Here for the decline part, it's improving and remaining totally dependent. So two factors are measured for each of those indicators, for the mid-loss and the same for the early loss. The fourth grouping we're going to look at takes in the late loss, mid-loss, and early loss ADLs all in one measure. And here we're looking at the ADL long form, which is a measure that goes from 0 to 28, 28 meaning higher functional disability, and a 0 meaning independent in those areas. Now notice for the late, mid, and early loss ADLs, that includes bed eating, toileting, and transfer again, but it also includes locomotion on the unit and dressing and personal hygiene. So all of those factors are going to come into that ADL measure. It's actually a measure I quite like, this one right here. I think it's a very appropriate measure. It gives us a much broader range of score for individuals in that it goes from 0 all the way to a 28 score. Obviously, someone who has a 28 has, a functional disability in all of these areas, which is quite meaningful from someone who's a 0 and does not have any disability in all of those areas. So I think that's quite a good measure, this ADL score. The last one we're going to look at, the group 5, is locomotion. And notice also for this one ADL, we're only looking at decline. We're not looking at improvement and decline. There's only a decline indicator. And then locomotion on the unit. And here we're going to look again at improvement, and we're going to look at decline as well. So those are all the items that we have to cover today, so it's quite extensive. I'm going to just skip through this part. I've introduced this over time and time again. So if we could get you just to move right along. And you can see here that the items that we're looking to cover today are part of the improvement indicators. You can see that it's number 6 through 9, improved late loss ADL, improved locomotion, whether one improved or remained independent in early loss ADLs, whether or not one improved or remained independent in the mid-loss ADLs. So those are the improvement indicators, and then we're looking at the decline indicators. And here we have the worsened ADL. Recall that that's the indicator that encompasses both early, mid, and late loss ADLs. Then we have a worsened late loss ADL indicator, which is bed eating, toileting, and transfer. We have the worsened locomotion, and we have whether or not there's worsened or remained dependent in early loss ADLs, worsen or remain dependent in mid-loss ADLs. And notice that the decline indicators are just the flip of the improvement indicators. So once we know how to calculate the one, we know exactly how to calculate the other. It's just the reverse of it. Okay, once again, from the set of items that I show you each week, let's just review. The only one we have on the Health Quality Ontario is a measure of worsened ADL. The gold standard is set that they're wanting the province to achieve a 25% rate on that particular gold standard. And currently for Q2, and I'm not sure if everybody's aware, but the Q2 results are now out at CIHI. So all of the data that ends in September is now available for reporting if you want to run your reports on the CIHI webpage. And notice that the current value is 33%, or 33.33%, and we're working our way down to a 25% gold standard. There is a wrap and a cap related to this particular indicator, And we're going to look at both of those in just a moment. And both of those, the CAP and the RAP, the resident assessment protocols and the clinical assessment protocols, look at risk of someone experiencing a negative event or some event. Okay, once again, I want to just mention Carol Estabrook and company out of University of Alberta. And again, looking at these areas that are sensitive to nursing practice. And you'll notice that this particular item does not have a standard set by the sensitive to nursing practice that was published by the Estabrook and Company. Okay. Now, there's some scales that we're going to use as we're going through these calculations, and this is where the complication comes into it. The first one is this one called the ADL hierarchy scale, of which you know there are several performance scales that result out of the MDS data elements. And here you can see the scale goes from 6 down to 0 on the hierarchy scale. And the items that we're using are the locomotion on unit, the eating item, toileting item, and personal hygiene. So those are the 4 data elements that we're working with. You can see here for locomotion on unit, if it's a 4 and an 8, and now notice these are all and operators. So all of these conditions have to exist. So here we're going to put you at the very top of the scale for disability. If your locomotion, eating, toileting, and personal hygiene shows that you're totally dependent over the 7-day window, or the activity did not happen in any of the 7 days. So either one of those conditions and all of these 4 different activities will put you at the very top of the scale. This time we're going to look at item locomotion and eating only. And if you're totally independent or activity didn't happen on those 2 items, then you're a 5 on the scale. Again, you can see here if your score is a 3, that's extensive for eating and extensive for the locomotion. So notice that these are ors. They're not ands in the first condition where you're a 6. You had to have all 4 conditions in order to qualify to be a 6. Here it's this or that. Again, it's the same 2 items, but only at extensive performance. And then next on our list is the I and J item, which we see here is toileting and hygiene. And we're going to look at if you're a 3, 4, or an 8, right? Any one of those 3 values on the toileting, and any one of those 3 values on the personal hygiene, then your ADL hierarchy score is a 3. Next brings it down a little lower where we're looking at limited assistance, and again, they're all ors, that, or that, or that, or that, for all 4 of the items. And then your ADL hierarchy score is a 2. And then once again for the 4 items, if your limited assistance, if your supervision for those items, any one of them, then your ADL score is a 1. And now if you're independent for all 4 of them, then your ADL score will be 0. That is, you are fully functional in that area. So you can see what the ADL hierarchy is measuring. A 0 is independent, a 1 is supervision, 2 score is limited. Excuse me. You can see we have 2 levels of extensive 1 and extensive 2, and then we have dependent and totally dependent if you scored a 6 on that scale. So we're just going to keep that measure in mind called the ADL hierarchy. It's a definition that we have to be aware of. Now I've talked about the cognitive performance scale. Again, this is the 3rd time that we've discussed this, so I'm not going to go through the whole details of how it's calculated again. We know it goes from 0 to 6, which means you're intact for cognition or you have a very severe impairment. And so that scale will play a role as well. Now the ADL long form, which I mentioned earlier, the one that measures the early, mid, and late loss ADLs, we're going to look at how that particular scale is calculated. You can see it goes from 0 to 28, with higher values indicating greater difficulty in performing activities. The ADL's long form is just simply add up the values. Okay, now there is one provision here. If you scored an 8, that is every one of the 7 days of observation the activity didn't happen, we're going to recode all the 8s into 4s, totally dependent. And this happens quite a few times on the MDS outcomes. You'll see that 8 is often rescored into a 4, indicating total dependency. And these are the items that we're looking at across that scale. These 7 different items, and 4 7s are 28. Now there are some exclusions, so if we look at the late loss ADL and both for improvement and decline on late loss, people with end stage will be excluded with hospice, or if you're in a coma. So those will not come on to the calculation of your quality indicator if any one of those 3 conditions are present on the assessment. We're going to look at improvement, and obviously there's going to be an exclusion here in the fact that if you were totally independent on the last assessment, then you obviously cannot get better than totally independent, and anyone totally independent or 0 on all 4 items are going to be excluded from the calculation. And the reverse is true. When we look at worsened late loss ADLs, anyone who was a 4 or an 8 on all of the 4 items, bed, eating, toileting, and transfer, they're going to be excluded because you can't get worse than total. Okay? For the mid-loss ADLs, we were here again looking at improvement and remaining completely independent. Okay, and we're looking at percent of residents who mid-loss ADL transfer and locomotion worsened or who remained dependent, completely dependent. There are no exclusions for this one, and for the early loss ADLs on improvement and late loss and decline, there are no further exclusions other than the 3 standard ones that we see here. And then we have the, once again, the late, mid, and early loss. ADL, percent of residents whose ADL performance worsened on all of these areas. That's bed mobility, eating, toileting, transfer, dressing, and hygiene. That's that ADL index score, the ADL long form. And there are no exclusions on that particular indicator as well, other than end stage hospice and comatose. Locomotion on unit, we're looking both at improvement and decline here. And then obviously we're only looking at one item, G1E, and I'm not even sure why it's an indicator all by itself, since locomotion seems to appear in several calculations. However, if you were totally independent on your previous assessment, obviously you cannot improve, so you're going to be excluded. If you were totally dependent on your previous assessment, you can't get worse than total, therefore you're going to be excluded from the calculation. Okay? So then let's go on to the next. Just look at the section of the MDS that we're dealing with, G1. You can see that this is the scale, the performance scale. And we can see here that we're looking at bed mobility, transfer, locomotion, dressing, eating, toileting, and the personal hygiene items. So those are the items that will trigger these quality indicators. So the improved and late loss ADL is what we're going to look at right now. And there's 2 different ways to trigger this indicator. Now, if the current ADL is less than the prior ADL by at least 1 point, then we're going to create a new item called improved 1. Okay? So here you can see improved 1 is the new item. We start at 0. And if your previous ADL score for bed, eating, toileting, and transfer now, this is what we're looking at for each of them. If you can see that your current score is less than your previous score, then you can see then you've improved by 1. Okay, and you get a point. And that's for each of the 4 items, so you can see that you can get up to 4. Now, on the if the current ADL is greater than the prior ADL by at least 2 points, then this new item called improved 2 will come into play. And the actual trigger is this. If you've improved in 2 items, 2 of these items, by at least 1 point, then you're going to trigger the quality indicator. So you could have 0, 0, 1, and 1. That would trigger if on the prior assessment you had all zeros, and now you've got 0, 0, 1, and 1, 2 of the items improved by 1 point at least. That would trigger this quality indicator. Down here, the change has to be 2 points, but it can be 2 points on just any one of the 4 items. So if at least any one of the 4 items improved by 2 points, then you will have improved. Okay? So either one of those situations will give you exactly what you need. So if your previous score was greater than, if your current score is greater than your prior score by at least 2 points. Okay, now for the decline indicators, we're looking at, you know what, guys, I am so sorry. Less than your prior, and I put greater than here. Let me just correct this slide, please. Obviously, if your current score for eating is smaller than your prior score, then you've had an improvement. You went from a 4 total to a 3, let's say, for extensive, then you would have had an improvement. And this should have said less than, not greater than. I do apologize. All right, and the worsen indicator is the opposite, right? If your current ADL score, so eating, let's say, is greater than it was before, then you've had a decline in your eating ADL. And you get 1 point each and every time to calculate how many of these happened. And then obviously on the second part, what we're looking at is whether or not any one of the items, or at least one of the items, shows that you've got a greater score by at least 2 points, then you'll trigger the indicator as well. So any two items by 1 point, any one item by 2 point is the rule. And either one of those conditions will cause you to trigger this quality indicator. The mid-loss ADLs, here we're looking at the items B, D, and E. And recall that B is transfer. D is looking at the, D is looking at the hygiene, and E is looking at locomotion. Okay? The mid-loss ADLs is looking strictly at, this is for worsened, and you can see it's the same 3 items that we had before. And we're just going to add them up. And we look at for both of these, we're looking at your current score, and we're looking at your previous score when you add up those 3 items. And we can see here that if the current mid-loss ADL is greater than the prior mid-loss ADL, then you'll trigger. Or if your current ADL was 12 and your previous score was a 12, then you can see that you remain totally dependent. So that's the two different situations. If your score is greater or your score is maxed out on both of them, then you're going to trigger this particular quality indicator as well. All right, let's move on to the next set of slides. We're looking at the early loss ADLs, and the early loss ADL is item G and item J. So dressing and personal hygiene are considered early loss ADLs. And we're looking at improvement on early loss ADL functioning or remaining completely independent. And so you can see again, that's the same thing. Did you improve or are you completely independent? And if either one of those conditions, then you will trigger that particular indicator. Now we're looking at the decline side of those indicators. And again, it's the same two items that we're working with, dressing and hygiene. We're going to add the two scores up, and you can see that these two scores can reach a total value of 8. 4 and 4 is the maximum score. 0 would be the minimum score. And we're looking here that if your current early loss ADL is greater than your prior ADL, so if your current total score is higher than it was on the previous assessment, then you'll trigger. But also notice that if you were maxed out, that's totally dependent on the previous, and you're still maxed out, then you will also trigger this particular item. Okay, and then the ADL long form is the one we spoke of several times, one where we're measuring the early loss, mid loss, and late loss ADLs. And you can see it's just the same thing over and over and over and over again. Now here we're only looking at decline. And so the current ADL long form is greater than the prior ADL long form, then you're going to trigger, okay? So if your current score is now larger than your prior score, then you've triggered a decline in overall ADL status. And now the last one is locomotion, and we talked about locomotion both for improvement and decline. Only one item we're working with, that is G1E, locomotion on unit, and the self-performance part. And improvement would be where your current score is less than your previous score. So you had a higher score before when higher score meant disability, and now your current score is less than it was, so you will trigger this on that one item alone. And then worsened is obviously the opposite. If your current score is greater than the prior score, then you will trigger this particular indicator on locomotion. So very simple, very straightforward. Now with the RAPs, you can see that there are RAPs, and RAP is ADL functional rehab potential. You can see all of the different items that make up that RAP, so that you've got either not triggered or triggered is the outcome. Notice that all of the ADLs are here, along with the bathing ADL, which we haven't seen before. So this risk indicator includes the bathing ADL on the performance. It also includes the items from G8. And remember, G8 is the resident believes they're capable of increased independence. The staff believe that the resident is capable of increased independence. And then B4, cognitive skills for decision making, also comes in as a risk factor related to ADL potential. So if you have severe problems with decision making, then you're less rehab potential. So notice the word potential here. And it's simply just a matter of looking at the combinations of these, whether or not you trigger each of these RAPs. So, and notice they're all ORs. So if any one of these items here, we're looking at a 1, 2, 3, 4, 1, 2, 3, 4, so anything above independent, right, is going to say you're at risk. So if you're supervision limited, extensive, or total, you're going to trigger. And we're also looking here for item G8. If you said yes to those, then you will also trigger this particular item. And that's called the rehab side. So you should consider rehab. Now here it's on the maintenance side, and it says if your decision making, right, and your ADL trigger is a 1, then ADL will be triggered as a 1. So if decision making is totally dependent. And then here the ADL functional rehab gives you the calculation, and these are all of the items that are used for it. So rather straightforward. Looking at lots of the items from section G, G1, G2, G8, and one item B4 from the cognitive section. The CAPS is very similar, but now we're going to bring in other items around activities of daily living. We're not looking at rehab potential now. Now we're looking at disability, so you can, or risk, negative risk. So end stage, acute episode of flare-ups, hip fractures, overall change in overall health status from section Q, hospital stays, change in ADL function, that's the overall section G, you know, whether or not you've remained the same, improved or deteriorated since your last assessment. Pneumonia comes into play here, and now these are the delirium items, the B5 items. Altered perception, restlessness, lethargy, mental functioning varying over time. Change in cognitive status also plays a role to put you at risk around activities of daily living. The fact that you require days of physical therapy is also a risk factor, and the fact that you fell in the last 30 days is a risk factor. So then we're bringing in this scale that is your prerequisite. You have to have the cognitive performance scale and the ADL hierarchy scale. And we talked about those calculations at the very beginning. So we're going to use those. There's this long string of variables here, and you can see what happens is that you're looking at whether or not each of these items are triggered, the ones that we've discussed here. Every time you've triggered one of those items or qualified for one of those items, you can see you're going to get a score. So you go from 0 to 1 to 2, 3, 4, 5, 6, 7, 8, 9, 10, and 13 possible points on that scale. All right? And then the cap is triggered in this way. If your CPS scale is less than or equal to 5, so you're not totaled on the cognitive performance. If you're not in end-stage disease, if your ADL hierarchy score is a 1, 2, 3, 4, or 5, then you're going to score, right, on that a 2 on the cap. Else, if that living 13-point scale that we just looked at, if it's in the low end, you're highly independent for all those factors, then you're going to be a 1 on the cap, else you're going to be a 0. So what does that mean? Well, 0 means not triggered, 1 means triggered to prevent decline, and 2 means triggered to facilitate improvement. So those are the outcomes that the activities of daily living cap are looking at. Quite a bit different than what the RAP was measuring. Now I know I'm a little bit over, so bear with me for just another 2 minutes. We're all familiar with the rugs. This is the rug 44 grouper. We know in nursing homes we use the 34 grouper, and as I've said before, they're identical. What areas of funding do ADLs impact? Well, bed, eating, toileting, and transfer impact every single one of the 44 groups or 34 groups. By far, bed, eating, toileting, and transfer are the most important items to ensure that we have accurate and complete coding. They impact every single funding group. And I just want to give you one simple example. Look at the reduced physical functioning with 2 or more nursing rehabs. If you look at the very bottom group here where your ADL score is 4 to 5, you're at the 44th lowest funded group. So that's 63 on the CMI. Notice if your ADL scores go up from 4 to 5 to 6 to 8, 9 to 10, 11 to 13, you go from the 27th highest funded group up all the way down to the 44th. 17 levels of funding you drop. Now, if you combine nursing rehab with ADL, you go from the 26th group down to the 44th group with lower ADL and less than 2 nursing rehabs. So you can see here that you're dropping 18 different levels of funding with respect to only ADLs only. And you can see all across here, ADL, ADL, ADL impacts funding in an enormous way. So ADLs have to be considered. I would never let anyone submit data, unless I've actually done a review of all the bed eating, toileting, and transfer. Okay, so thank you. I went over to 3 minutes here, 5 minutes actually. I apologize. And but it was a lot of material to have to cover in that very short period of time. Thank you, all of you, for participating today. And I believe this is our last session for the year. And we start again in the new year, if I'm not mistaken. Any questions, please leave them with Heidi. I'd be happy to answer them. Any areas that I messed up, let me know if I messed it up and I'll correct any mistakes I've made. Or if you have any other questions that you'd like to ask me, please just email me, paul@medic-care.com. Thank you. Bye-bye.